Okay. The next speaker, the second speaker for this session will be Dr. Adam Hastings. Dr. Hastings is a clinical associate professor from the University of Sydney. He is a consultant anaesthetist and practicing in Sydney. He has extensive experience in neuroanesthesia, intraoperative neuromonitoring, cardiac anesthesia, and perfusion. Adam is the program director of the Master in Medicine Clinical Neurophysiology degree at the University of Sydney, which he and colleagues developed in 2015 to provide educational activities and promote best practice clinical care within the multidisciplinary workforce in Australia and New Zealand. Adam is also the board member of the Intraoperative Society of Asia Pacific and has been instrumental in the development and delivery of intraoperative neuromonitoring conference in Australia. And he will now present a lecture on anesthesia considerations during the intraoperative neuromonitoring. Thank you, Dr. Hastings.
Hello, I'm Adam Hastings. I'm an anaesthetist at Westmead Hospital and an associate professor at the University of Sydney. I'm a consultant anaesthetist, and my specialty areas are neuroanesthesia, neuromonitoring, cardiac anesthesia, and cardiac perfusion. I've been asked to speak to you today about the anaesthetic considerations during intraoperative neuromonitoring cases. More than half of my clinical practice is in neuroanesthesia, and the vast majority of that is providing neuroanesthetic services for intracranial neurosurgery. And I also provide intraoperative monitoring services for the surgeon that I work for, so very frequently I'm actually providing the anaesthetic and the monitoring services for the same patient at the same time, which confers some benefits but also has some downsides to it. And in planning this lecture, I thought about the sorts of things that go through my head when I'm heading into an anaesthetic in which I'm planning to provide monitoring as well. So general anaesthesia, which is the predominant method of providing anaesthesia for patients having intracranial neurosurgery, is really a balancing act. There are several components to it, and each one of them is important, and each one of them has its own requirements and interactions with the other components. So unconsciousness and amnesia, having a patient who is unaware of what is going on and has no recollection of those unpleasant events. Analgesia, so good pain relief, and antinociception, so blocking the incoming pain signals to avoid unpleasant effects and to avoid sympathetic stimulation effects and to try and avoid wind-up. Immobility, to provide a motionless surgical field for the surgeons and trying to maintain systemic homeostasis such that the patient's well-being is ensured during the operation. Now, obviously, there's a big interplay between anaesthesia and the provision of monitoring services. Both have their particular demands, and defining those requirements and finding the middle ground, finding a way to get through the operation that meets all the requirements of both the anaesthetic and monitoring is of extreme importance. We really do need a hemodynamically stable patient for whom all of the significant neuromuscular and neural pathways are intact, warm, well perfused, functioning appropriately. We need a quiet operative environment where there isn't significant drug-induced impairment of neurophysiological function in order for us to be able to do monitoring appropriately and effectively. We need to have neuromuscular activity such that it's elicitable and quantifiable, but we don't want to have unwanted or excessive movement in the operative field, which would mask the signals and cause problems with the operation. And surgeons and anaesthetists alike want the patients to have a rapid, smooth emergence with normal post-operative neural and neuromuscular function so that they can be assessed clinically for the success and or complications of the procedure that has been performed. There are many, many ways to skin a cat, goes the saying, and there are many, many ways to provide an anaesthetic for any operation in any patient. And there are multiple approaches and there are multiple techniques, and they're often all possible, or many of them are possible, and they're often equally valid. And the particular technique that is selected by the anaesthetist at the time is very much influenced by patient factors such as age and comorbidities, the operation proposed, and what the goals are of the monitoring and the modalities that are going to be used. And not surprisingly, it's the most demanding modalities in terms of their requirements that dictate often what sort of anaesthetic is provided. So if we consider the first goal of anaesthesia being unconsciousness and amnesia, this is really only achievable through the systemic administration of hypnotic agents, either via the intravascular or the inhaled route. And the onset of anaesthesia, the onset of amnesia and anaesthesia is really non-linear. It can be highly unpredictable. It's highly variable in person to person. And the transition from an awake state to a loss of consciousness is often very abrupt. The most common medications that we use for providing hypnosis in neuroanaesthetic are the volatile agents and propofol. Ketamine is not infrequently used. Dexmedetomidine is a fantastic adjuvant agent. And in countries outside of Australia, etomidate is also sometimes given. When hypnotic agents are administered, their effects are usually monitored by examining frontal EEG changes, and we try to use those EEG changes as well as clinical indicators to titrate the drug administration to achieve the desired anaesthetic level or plane. Now, when looking at general anaesthetic, a very frequent and very common combination is an IV induction, either with thiopentone or propofol or any of the other agents, supplemented with opioid boluses or an infusion, and then a transition to volatile anaesthesia for anaesthetic maintenance, along with adjuvant medications. But it has significant detractions when considering neuroanaesthesia and the requirements of neuromonitoring. Increasingly, total intravenous anaesthesia is being employed not only for neuroanaesthetic but for other more general anaesthetic techniques because it does confer some decided advantages. Total intravenous anaesthesia, or TIVA, is usually given in two formats, either by mass-based dosing, where the patient's weight is multiplied by a particular dose per kilo, either as a bolus or over a particular time frame for an infusion. But increasingly commonly, these medications are given with a target-controlled infusion. The most common drug combination used for TCI is remifentanil and propofol, but this can be and is often supplemented with other agents, for example, ketamine and dexmedetomidine, both of which have hypnotic sparing effects and so allow us to reduce the use or reduce the amount of, for example, propofol that is used for that particular patient. Inhaled anaesthetics, on the other hand, or otherwise known as volatile anaesthetic, have effects on multiple different receptor systems throughout the nervous system and generally have a depressant effect. And their effects are largely mediated by postsynaptic inhibition through GABA receptors. They have multiple effects clinically in as much as they produce amnesia at sub-anesthetic doses, they produce unconsciousness at higher doses, and at even higher doses again they produce immobility. But this is offset by the fact that they are quite potent vasodilators, causing significant hypotension. They have cardiovascular depressant effects. But significantly, they disrupt the coupling between cerebral metabolic rate and cerebral blood flow, which results in an increased cerebral blood volume. The depressant effect of volatile agents is most noted in polysynaptic pathways, which is why volatile or inhaled anesthetic agents are particularly detrimental in trying to monitor long-track pathways that have polysynaptic components to them, for example, SSEPs and motor evoked potentials. And this is a dose-dependent response. The most commonly used volatile anaesthetics in modern-day clinical practice are isoflurane, desflurane, and sevoflurane, and they have differing properties, including different blood-gas partition coefficients, which impart upon them different solubilities and hence different onset and offset times. But they also have different potencies, such that a means by which to compare potency and determine equipotent dosing between volatiles was developed, and this is referred to as the MAC, or minimum alveolar concentration, which is arbitrarily defined as the steady state alveolar concentration of the anaesthetic gas in question, at which 50% of young healthy volunteers will not move in response to an abdominal skin incision. The problem with MAC is that it's highly influenced by a number of factors, not the least of which being age and comorbid state. We know that for volatile agents, amnesia occurs at much less than 1 MAC. We know that loss of consciousness will often occur at around about 1 MAC, and we know that as a sole agent, we would need approximately 1.5 MAC worth of that particular agent in order to maintain adequate general anesthesia and immobility. And paralleling the target-controlled infusions that we see in intravenous anesthetics, there is also increasing use of end-tidal concentration control systems where the amount of volatile agent administered to the patient is automatically controlled in order to establish and maintain a particular end-tidal concentration and hence a particular MAC of that volatile agent. It is well known that moderate to high doses of volatile anesthetics have a detrimental effect on intraoperative neuromonitoring, particularly on monitoring of somatosensory evoked potentials and motor evoked potentials. Because volatile agents exert their effect through synaptic inhibition, it is not surprising that SSEP responses are well preserved even with high dose volatiles when looking at peripheral and presynaptic responses. That is, peripheral responses, epidural responses, and cervical responses are all well maintained in the presence of increasing doses of volatile agent. However, cortical responses are significantly suppressed for administration rates of volatiles in excess of about 0.5 or 1/2 of a MAC equivalent. As we can see in this graph, regardless of the concentration of isoflurane that is administered, the epidural responses, and certainly this reflects peripheral responses as well, are maintained. Cervical responses, which are presynaptic, are also maintained, whereas the cortical responses are significantly affected by increasing concentrations of volatile, both in terms of amplitude reduction and increased latency. And we can see as the isoflurane concentration is increased to 0.6%, which is about 1/2 a MAC, we start to see some changes in the cortical responses at 0.9, 1.2%, getting closer to 1 MAC of isoflurane here. There is significant impact upon these cortical responses. Volatile agents have significant effects on motor evoked potentials as well, due to their inhibition of synaptic transmission in the motor cortex with all the interneurons here that are responsible for the indirect waves that we see when we stimulate the motor cortex, as well as in the anterior horn of the spinal cord, where the descending motor pathways synapse on the lower motor neuron or the alpha motor neuron, as well as inhibition at the neuromuscular junction. And this causes profound suppression of motor evoked potential responses. We can see the effect of isoflurane on motor evoked potential responses here with a single cranial stimulus at doses of about 1/4 MAC. There is profound suppression of the response. This suppression can be at least partially reversed by using multi-pulse stimuli, and the use of such stimuli allow us to maintain MEP responses well up here into 0.6% isoflurane, which is about 1/2 a MAC. At doses exceeding about 0.5 MAC of any anesthetic agent, we begin to see significant suppression of motor evoked potentials. So it's important for us to know what medications we can use for particular neuromonitoring studies and what medications we can't use or should be best avoided, or at least take into account that they might have an effect upon the waveforms being generated and that might impair our ability to detect surgically induced changes. So this is a very complicated table, but the important things to point out are that if you're doing brainstem auditory evoked potentials, it really doesn't matter what medication you use because they're very, very resistant to anesthetic. And the other thing to note is that opioids and the alpha-2 agonist dexmedetomidine really don't have any significant effect on any modality for monitoring. On the other hand, visual evoked potentials are profoundly affected. In fact, they're the most sensitive EP study. Interestingly, etomidate and ketamine stand out as agents where they don't significantly impair the ability to detect changes in SSEPs and transcranial motor evoked potentials. And in fact, etomidate and ketamine have been known to improve responses in terms of response amplitude in both SSEPs and transcranial MEPs, which can be helpful in the setting of difficulty in establishing responses. So we've spoken about EPs, but we have to consider other modalities. And in considering EEG, it's important to realise that ostensibly all anaesthetic drugs have dose-dependent effects on EEG. They have characteristic EEG signatures. And so as long as generalised burst suppression is avoided, we should be able to detect regional differences in EEG activity that might be suggestive of cortical ischemia. And in considering EMG responses, with the obvious exception of neuromuscular blockade drugs, there is ostensibly no effect of any anaesthetic drug on spontaneous EMG, and nor is there significant effect on the EMG responses that are triggered by peripheral stimulation. As mentioned before, brainstem auditory evoked potentials are highly resistant to anaesthetic, and we can see in this particular graph, with increasing doses of isoflurane up to almost 2 Mach, a small increase in the latency of the waveforms of interest, but really this wouldn't impact our ability to monitor appropriately. On the other hand, mid-latency auditory evoked potentials, which represent the transmission of those auditory signals out to the auditory cortex, are affected by both volatile agents and intravenous agents, particularly propofol, here shown with increasing concentrations of target-controlled propofol infusions, and we can see latency and amplitude changes. Now, propofol is the standard anaesthetic hypnotic agent used in general anaesthesia. Propofol enhances GABA-mediated synaptic inhibition, and that constitutes the majority of its discernible effects. It has direct cortical suppressant effects, especially in the frontal lobes and the parietal lobes, and it inhibits thalamocortical networks, and particularly the thalamic reticular nucleus. Propofol causes much less synaptic transmission blockade than volatile anaesthetic agents. And because we have complex pharmacokinetic models and we have the ability to do targeted controlled infusions, we can maintain propofol levels quite accurately, titrated to clinical requirement, and as such, it is highly suited to anaesthesia in the setting of intraoperative neuromonitoring. And when we consider propofol and remifentanil, we know that they are synergistic. That is, that each medication has a more than additive effect on the other medication in terms of producing amnesia and unconsciousness. When we look at the combinations of these medications and the combinations of concentrations and the likelihood of a response to a noxious stimuli, for example, laryngoscopy, we can plot out a series of curves that represent equal probability of response, and these are called isoboles. When we plot those isoboles in three-dimensional space, we have an isobologram or a response surface plot. And we can consider where we fall upon this response surface plot at any one point in time. In order to obtain unconsciousness and a lack of response, we need to climb up the hill of this response surface plot to the upper plateau. This is essentially the target area for anaesthesia, and we start at the bottom of the hill. And we can either climb the hill by using lots and lots of propofol and then a little bit of remifentanil and get up onto that plateau quite easily, or we can climb the hill by using lots and lots of remifentanil and then a little bit of propofol to get up onto that plateau of the response surface plot. And the combination that we choose, the method by which we climb up onto this response plateau, is influenced by our knowledge of those drug kinetics. And knowing that remifentanil will be eliminated more rapidly than propofol leads us to use higher doses of remifentanil and lower doses of propofol. And this is beneficial in terms of monitoring because the lower the dose of propofol, the more likely we are to be able to monitor the patients. Analgesia is another significant consideration intraoperatively, both the minimization of intraoperative nociception and the promotion of postoperative analgesia. And generally speaking, in anaesthesia, we can use regional approaches, including neuraxial and plexus blockade, or we can use peripheral approaches, including peripheral nerve blockade and local infiltration. But those techniques tend to impair significantly with intraoperative neuromonitoring. The most common approach is to use systemic polypharmaceutical management of analgesia intraoperatively in cases associated with the use of intraoperative neuromonitoring, and this relies heavily on the use of opioids, paracetamol, non-steroidals, and also might include the alpha-2 agonists such as clonidine and dexmedetomidine, and the NMDA antagonists such as ketamine. Opioid agents are the backbone of analgesia intraoperatively, and they exert their effects through opioid receptors. Although opioid agents cause a generalized slowing of EEG, they have relatively little effect on EMG responses and certainly on evoked responses. And when used as part of a balanced anesthetic with hypnotic agents, they allow the reduction in the dose required of the hypnotic agents, which themselves might have suppressant effects. When added to high doses of hypnotic agents, they may actually potentiate the depressant effects of those other agents. So it's important to dose reduce when you're adding opioids into hypnotic agents, and that is the backbone of balanced anesthetic approaches. The most commonly used opioids are remifentanil, which is actually a fairly poor analgesic, but it's a highly potent sympatholytic drug and a very potent hypnotic sparing agent. Immobility is another important consideration in anaesthesia because the provision of adequate operating conditions is paramount to the safe and effective conduct of surgery. And this often involves the administration of neuromuscular blockade, but does not strictly require it. Indeed, high doses of volatiles and high doses of remifentanil alone can cause sufficient immobility that neuromuscular blockade is not required. And while neuromuscular blockade mitigates against undesired movement and improves respiratory mechanics intraoperatively and improves body cavity access and body positioning, it also comes at a cost. And that cost is the risk of significant postoperative morbidity associated with incomplete and inadequate reversal of neuromuscular blockade, and also the risk of masked intraoperative awareness where the patient who receives inadequate hypnosis is aware under anaesthesia but is unable to communicate or move in any way due to neuromuscular blockade. Neuromuscular blocking drugs obviously have an effect on monitoring protocols which require muscle responses, so EMG type responses and motor evoked potentials. It was demonstrated by Todd Sloan in 2013 in his review of the effect of neuromuscular blockades on motor evoked potentials that you can actually adequately perform motor evoked potentials in the presence of residual neuromuscular blockade. Indeed, with blockade up to a train of 4 count of about 2, which constitutes approximately 80 to 85% of the receptors blocked by the neuromuscular blocking agent, you can still get fairly reliable MEP responses, albeit at a reduced amplitude to the responses that occur in the absence of neuromuscular blockade. However, this is in neurological normal individuals, and in individuals who have impaired neuromuscular responses already, even tiny doses or tiny residual doses of neuromuscular blockade can completely inhibit the ability to determine neuromuscular and MEP responses. Systemic homeostasis is a highly important consideration during anaesthesia, and indeed almost every intervention undertaken to obtain unconsciousness, to obtain amnesia, to induce analgesia and immobility causes significant derangements in multiple systems, including the cardiovascular, respiratory, and neurological systems. And much of the time and attention and effort of anaesthetists is devoted towards minimizing and stabilizing and reversing these changes to try and maintain that patient within an acceptable band of parameters intraoperatively. Any systemic deviations in these parameters have to be corrected before intraoperative neuromonitoring changes can be attributed to localized neurological dysfunction. So the goal for the anaesthetist is to maintain organ and peripheral oxygenation, and this requires maintaining adequate forward flow from the heart or cardiac output, maintaining an adequate driving pressure, reflected often in the mean arterial or systolic pressures, and adequate oxygen carrying capacity. So ensuring that the hemoglobin and the hematocrit are sufficient to provide oxygen to the tissues. The last major consideration that I have to talk about is that of intraoperative hypothermia. And inadvertent intraoperative hypothermia has multiple adverse consequences for the patient, including increased bleeding risk, the increased risk of wound infections, the increased risk of cardiovascular events, including acute myocardial infarction. But significantly for intraoperative neuromonitoring, hypothermia impairs neural conduction velocities and synaptic function, and this is borne out as an increased latency and sometimes a decreased amplitude of responses. And this is borne out as both an increased latency and decreased amplitude of responses in evoked potentials. While there are many mechanisms of intraoperative heat loss, including convection, radiation, evaporation, and conduction, the biggest cause of inadvertent hypothermia intraoperatively is actually redistribution, wherein the normally higher temperature and heat capacity of the core of the body is distributed peripherally due to induced vasodilatation from the induction of anesthesia. And this is most adequately dealt with and most effectively dealt with by vigorous pre-warming of the patient prior to induction of anesthesia. It is important that great care is given to ensuring the maintenance of normothermia for all patients undergoing procedures, particularly those with prolonged procedures and with large areas of body exposure. So in this talk, we've had a look at a number of the considerations that are relevant to the conduct of anesthesia in the setting of intraoperative neuromonitoring for surgical intervention. There are a number of conflicting priorities, both within the anaesthetic and between the anaesthetic and the neuromonitoring requirements. And it is certain that successful monitoring requires a coordinated team effort.
All right. Thank you very much, Dr. Hastings, for this beautiful lecture. And again, how are you doing? I'm good to see you online there. And we do have some questions from the floor. The first one being from Dr. Robert Chen. If we need intraoperative neuromonitoring and ECOG at the same session for epilepsy surgery, what will be the best anesthesia and how to balance it? And
okay,
besides that, yeah, go ahead.
Thanks for that question. That's a very good question. In fact, we do electrocorticography cases quite frequently. The most important considerations for this is avoiding medications that will impair the ability to detect epileptogenic foci. So you definitely want to avoid barbiturates, you want to avoid benzodiazepines, and we try and avoid propofol as well. So most commonly our approach to this is to use a very balanced anesthetic using high doses of dexmedetomidine, a moderate to high dose of remifentanil, and then supplementing that with volatile. We usually use a very restrictive dose of propofol just for the induction, and then continue on with dexmedetomidine, remifentanil, and usually some sevoflurane or desflurane. And you can normally get away with about 0.3 to 0.4 MAC equivalent of that. So it's a very low dose, and we find that that gives a very good result for intraoperative electrocorticography.
Excellent, thank you. And this question from Dr. Yu, and she's just wondering, is the frontal lead monitoring BIS in kids reliable?
Is frontal leads monitoring of BIS in kids reliable? Well, that's a very good question. The answer is that BIS monitoring in any patient is completely unreliable. That in itself is a good 1 hour's long talk. In terms of children, certainly the protocols that were developed to run the BIS machine are not targeted at children at all. And the vast majority of my pediatric anesthesia colleagues would not rely heavily on that, on the data presented by it. But certainly an ability to assess the frontal lead EEG waveforms and to identify the changes that you expect to see with the induction of hypnosis and anesthesia, that's very reliable, both in children and in older age groups. There are certain changes in children that you're much more likely to see, and we have to just keep those in mind. But my number one piece of advice to anybody doing frontal EEG monitoring in any patient of any age is do not look at the number, look at the waveforms and tell me what you see and tell me what you expect to see, and does that correlate?
All right, thank you. Just one more question from the floor. Can we use the sugammadex intraoperatively to achieve better MEP? And if we need to use muscle relaxant again, which agents are most recommended?
So if you do use an induction dose of, for example, rocuronium or maybe even vecuronium, and then try and use sugammadex to offset that neuromuscular blockade, that's a very powerful technique to get good MEP responses. Sugammadex is not going to help you to any great extent if you don't have discernible neuromuscular blockade still in the patient. And if you do want to reparalyze that patient, then you would probably be best off using a neuromuscular blocking agent that's not rocuronium or vecuronium. So something like cisatracurium or atracurium would be much more potent because they're not going to be antagonized by the residual sugammadex.
Okay. All right. So thank you very much, Alan. And I think we are, because of the tight schedule. Thank you very much once again for your wonderful talk, and we certainly learned a lot from your talk. Thank you very much once again.
Cheers.